All right, thank you for and welcome for lecture number 10. Thank you, Eddie, to be there as an attendee. So let's start the lecture number 10 about cardiovascular system. All right. So let me see. Okay. So first of all, what we just need to remember is basic things. Number one, where is located the heart? All right, so probably it's not enough to say the thorax, but the thorax is being divided in many compartments. So I don't want to memorize the names of the compartments of the thorax. Just to mention here, we have the anterior mediastinum, middle mediastinum, posterior mediastinum, and superior mediastinum. So these are cavities that are the thorax are going to be divided. What we need to remember is just this, the middle mediastinum. Where is the heart? In the middle mediastinum. Okay, so that is the location of the heart. Then we have the pericardium. What is the pericardium? Uh, Students get confused. They confuse the epicardium with the pericardium. Pericardium, what it is just a double membrane that is going to surround the heart. So if you can imagine to put two plastic bags together, one inside the other one, and inside you put the heart. All what is surrounding that heart is going to be the pericardium. The pericardium, so it's a membrane that is surrounding. I am going to show you some pictures about it. And here, for example, let me see if I can move this. Here, can you see this picture? We have a layer covering the heart. That is the pericardium. Pericardium is a double layer membrane that is going to have a function. This function, you know, the heart is moving permanently. And what we have in the membranes, it has a double layer membrane, right? And in between this double layer membrane of the pericardium, we have fluid. It's about 30 cc or 30 ml of fluid. And the purpose of this is to decrease the friction of the heart with the surrounding tissue. The membrane, as we said, is a double layer membrane. We have the parietal and the visceral. The fluid that I was mentioning is going to be between the parietal and the visceral layer. Now, the parietal layer is going to be the outer layer of the membrane, where it's going to be close to the wall chest. And the visceral membrane is the one of the double layer membrane of the pericardium that is closer to the heart. Okay, so okay, here we have in this picture, you have the heart, and they are actually dissecting the portion of the pericardium. This pericardium here look like one layer, but actually it's two layers. And in between of this thin layer, we have the fluid, the pericardial fluid. So when you have, for example, the inflammation of the pericardium, that is called the pericarditis. Okay, so here we have again the middle mediastinum, and here's the location of the heart. The location of the heart is going to be, let me see if I put the video here, just to, the video, yeah, the video is on. Can you see me? Can you see me, Eddie? Eddie, are you there? Can you write me down if you are listening me, please, or watching me? I don't know what happened.
Can you hear me?
Yeah, I can hear you. Yeah, can you see me?
Yes.
Okay, perfect. So we are going to see the heart, very basic thing. We are going to see that the heart is like a pyramid. Let's make a pyramid here. This is a pyramid, okay, the pyramid. So the heart, actually what it's going to do is going to be like a pyramid like this, that this will be upside down. This heart is going to be from right to left moving and actually go posteriorly. And that is the position of the heart that you can see in the screen. where the apex,
Oh, okay.
the apex is going to be on the left side. Okay, so
Okay.
this apex belongs to the left ventricle, and there's many applications that we need to talk about apex, but apex is one of the structures that we must remember. Okay, it's going to be on the left side on the thorax and belongs to the left ventricle. Okay, so the components of the heart, we have chambers. Chambers, those are the cavities. We have the wall of the heart. We have the valves. We have vessels and electrical system. So all these components are very critical in order to understand the physiology of the heart. Number one, we talk about the three tissues layer, the layers of the heart. The layers of the heart, we have the endo, you know medical terminology, endo means inside. Myocardium is the lining of the cavities of the heart. Then we have the myocardium. Myo means, means muscle. And epicardium is the outer layer that belongs to the heart. So it looks similar as pericardium, but it's totally different. Epicardium is one of the three layers of the heart, and, and pericardium is the membrane surrounding the heart. All right, so let's keep going here. We have the septums. What are the septums? Septums are actually the walls. If the walls of the heart, let me see here. Okay, for example, this picture, we have a septum. So here we have the ventricle cavity, ventricular cavity. We have the atrial cavity. We have the atrial cavity, and here is a septum. This septum, because it's in between the two ventricles, is called the like international interventricular septum. Then we have another septum that are in between. On this picture doesn't have too much, but they are going to be in between the two atriums. So this septum is going to be called, it's a line that is going to be here, it's called the interatrial septum. And the last septum that we need to remember is this. Can you see here between the atrium and the ventricle, there is actually where it's going to rest the valves of the heart. This is called, because it's between the atriums and the ventricle, it's called the atrioventricular septum. So we have three
Okay.
septums. We have the interatrial septum, we have the interventricular septum, and we have the atrioventricular septum. All right, so let's keep going. Let me see, go back. Okay, so that are the three septums that we're talking about. Now we have the four chambers. Four chambers are the two atriums on the top and the two ventricles on the below that. All right, so here we need to start remember a few things here. Number one, the atriums that are located in the upper portion of the heart always are going to receive blood. Okay, so the right atrium is going to actually arrive blood to the right atrium, and the left ventricle, the left atrium, sorry, is going to receive blood. So the atriums always receive blood. Meantime, the ventricles are going to eject blood. So they're coming out and atriums coming in. In atriums, out ventricles. Okay, so let's start with the right atrium. The right atrium, we have this blue means deoxygenated blood, and the red means oxygenated blood. Let me see if I have another picture that could help us. Okay, here, for example, here we have the left atrium, and they are going to arrive blood from where? From the pulmonary veins. So what I want just to tell you here, that everything that is arriving or bringing blood to the heart are going to be called veins. Doesn't matter if there's oxygenated or deoxygenated blood. So again, so here these two branches or vessels that are coming into the left atrium are going to be called the pulmonary veins. Pulmonary veins. But veins, you think about venous blood, right? But they are actually what they are bringing is oxygenated blood. So atriums, we have the superior vena cava coming blood from the head and neck. We have the IVC of the inferior vena cava that is going to bring blood from the rest of the body. Then we have, again, the left atrium are going to be, and please, just remember we have 4 of these vessels, 4. 2 coming from the right lung, and the other 2 that you cannot see in this picture are coming from the left lung. So this is coming, bringing blood from the lungs, where they are being receiving already oxygen. So that's why it's going to be called by. But for definition, every vessel who bring blood to the heart, bring blood into the heart, are going to be called veins. So we have inferior vena cava again, inferior vena cava, superior vena cava, and the pulmonary veins. Then let's go to the ventricles. In the ventricles, we was mentioning that everything that is going to take out blood from the heart are going to be called arteries. So here we have the right ventricle. This right ventricle, and we have the left ventricle. So the right ventricle, what is going to appear here is the pulmonary artery. I said artery, but it's not oxygenated blood, because by definition, when we are talking about the heart, any vessel who take out blood from the heart are going to be called arteries. And every vessel who bring in blood are going to be veins. In this case, the ventricles are going to take blood from the heart to the lungs or to the rest of the body. So here we have the pulmonary artery, and the pulmonary artery is going to lead into, can you see the continuation here? Is going to divide into the right and to the left and to the right. So they are going to go directly to the lungs. So we have deoxygenated blood, and then when the blood is oxygenated by the lungs, they are going to come back. They are going to come back through the pulmonary veins. All right. So here we have the left ventricle, and the left ventricle we have, if you follow the arrow, the aorta is going behind the pulmonary artery, passing behind, and we have the arch of the aorta. So where is going to be the origin of the aorta? Is going to be the uh, left ventricle. Okay, so that is about the cavities. One thing I want just to mention here, always remember that the heart, we have the wall of the heart, and the left ventricle have a thicker myocardium, a thicker myocardium. And I think it's actually logical. Why? Because it's the aorta who is going to distribute the blood to the whole body. Meantime, the right ventricle is going to bring or take blood to the lungs that is actually short distance, right? So that's why the left ventricle have a thicker myocardium than the left ventricle, than the right ventricle, sorry. All right, so now we are going to talk about the valves. The valves, we have the tricuspid valve. So questions probably are coming like this. What structure are you going to you're going to find between the right atrium and the right ventricle? And the answer is going to be the tricuspid valve. Tricuspid valve. Why is tricuspid? Because we have three cusps, three valves actually, three cusps. Then we have the mitral valve on the left side that is called mitral or bicuspid valve. So if you see the Pope has a hat that they go for ceremonies, and this hat is called the mitra. This mitra means in Latin the mouth of a fish mouth. So that's why they have this similar appearance, and actually that's why it's called the mitral valve. Mitral valve. So we have the tricuspid valve, we have the mitral valve or bicuspid valve, and then we have another two valves that we need to remember. Here we have the pulmonary artery that is coming from the right ventricle, and these pulmonary artery valves are going to be called pulmonary aortic pulmonary artery valves, the pulmonary artery valves. Okay, now here the aorta is going to have valves here, and these valves will actually call the aortic valves. Aortic valves. I don't want to get confused on this. Just please remember this semi-lunar valve or semi-lunar valve. Semi-lunar valve we call both valves. When we talk and you tell me semi-lunar valves, in my head I'm going to think about the pulmonary artery valve and the aortic valve. If I want to be more specific, I will say pulmonary artery valve or aortic valve. But actually, semi-lunar valve is like the big umbrella for the both names, pulmonary artery valve and the aortic valve. If you have some questions or want me to repeat or clarify, just let me know, please, Eddie. Thank you. All right, so let's keep going. So we have the myocardium. The myocardium is a muscle that is, of course, is involuntary muscle, and they have different thickness. So you can see here, you just remember that the left side should be stronger because they are going to inject the blood to the rest of the body. So that's why the left ventricle is going to be thicker. So let's talk about the pulmonary circulation. All right, so the pulmonary circulation, and let me see if I have a picture here about, there you are. Here we have a nice pulmonary circulation. So we have two types of circulation. Number one, what I want you to remember about this pulmonary circulation is this. If you see here all the circuits, these circuits are going to be a closed circuit. So they are not going to drain any place. So it's totally a closed circuit, okay? And we have two main circulation. We have the pulmonary circulation. Look at this. This is the right ventricle going to the pulmonary artery. The pulmonary artery divide into two branches, right and left, and they go to the lungs. From the lungs, both sides are coming back after they make the gas exchange, and they are going to come back through the pulmonary veins that is in the left ventricle. So that is the pulmonary circuit or minor circuit. All right, so the circuit that goes starts from the right ventricle, they go to the pulmonary artery, they go to the pulmonary veins, and they end into the left atrium. So there's probably questions coming saying that what is the pathway of the pulmonary circulation? So pulmonary circulation you can remember with this. If you have an RV, you like RVs? Okay. So if you like RVs, let's go to LA. Let's go to LA. So RV is going to be the beginning. We have the right ventricle, and where it's going to end? Into LA, into the left atrium. So that's a way, yes, probably can help you to remember that. RV to LA. So RV means right ventricle, pulmonary artery, then go to the pulmonary veins, and then ends into the left atrium. So that's why it's called a small circuit or pulmonary circuit. Then we have the systemic circulation, and the systemic circulation is going to start in the left ventricle. So the pulmonary start in the ventricle, the systemic start in the ventricle too. The systemic start in the left ventricle, and the pulmonary start in the right ventricle. So let's continue with the systemic circulation that start with the left ventricle. They go to the aorta all the way. We are going to see the part of the aorta very soon. They are going to distribute the blood to the system. These represent the organs and muscles, any structure in the body, and these are the capillaries where the gas exchange is going to happen. The gas exchange, by the way, is occur in the capillary vein. So as long they go farther, they are going to deliver the oxygen, and the oxygen is going to be in less concentration. But at the same time, the cells are going to release carbon dioxide. This carbon dioxide is going to accumulate, and they are going to form they're going to get into the IVC, the inferior vena cava. And where is it going to end? Into the right atrium. So again, let's make it shorter. So left ventricle, aorta, body, IVC, right ventricle. Last time, left ventricle, aorta, the body, IVC, and the right atrium. Okay? All right, so let's keep going. All right, so one more thing that I want to make it probably easy to remember is number one. We have the right side of the heart. When you're talking about the right side of the heart, you're talking about the right atrium and the right ventricle. And the same thing when you're talking about the left side of the heart, you're talking about the left atrium and the left ventricle. So the right side is going to have deoxygenated blood. Deoxygenated blood. Meantime, the left side is going to have oxygenated blood. The atriums are going to receive blood, and the ventricles are going to eject blood. Okay, so let's see what else we have. So just to show you here some of the valves, we have the valves here. So this is actually the semilunar valves. Semilunar valves. This is the aorta. Can you see the aorta here? Okay, this is the pulmonary artery valve. We have the tricuspid here, and we have the bicuspid here. So this picture is not just to memorize. This picture is just to visualize how close are these valves from each other. So they are actually in one plane. All right, so one thing here. These valves, the bicuspid and the tricuspid, are going to be located in a septum. This septum is called the atrioventricular septum, as we mentioned at the beginning. All right, so one important thing, very important, very important. So you know the heart is going to give blood supply to the body, right? It's going to produce the flow of the blood in the body. And that is going to give blood supply to all the organs. But who is giving blood supply to the heart? So the first vessels that are coming out from the aorta are going to be called the coronary arteries. One on the left and one on the right. So here we have right coronary artery and we have left coronary artery. So as soon they get the blood ejected through from the left ventricle to the aorta, the blood is going to get into the coronary arteries. Coronary arteries are going to measure not that big. It's going to measure about 2-3 millimeters. That's all. And the lumen, when it's blocked with, for example, cholesterol, at 80% of blockage of the lumen, of the opening of the coronary artery, that are going to produce problems with oxygen supply to the myocardium. And that is producing what we call angina. So you will see that in the next slides, most likely. So here we have the distribution. So first question, where are coming from the coronary arteries? The coronary arteries are coming directly from the aorta, okay? So that is actually what is doing the coronary arteries, giving blood supply, oxygen supply, nutrition to the myocardium. Here just to show you about the functions of the valves. And I will see here if I can see, okay? So the valves, for example, this is the atrium, and here is the ventricle. So atriums and ventricles. How the blood flow is going to go through? Go from the atriums to the ventricles, correct? So the valves are going to be distributed like this, or the position of the ventricle of the valves are going to be. Now, coming blood from the atrium, open valve, but at the time when the heart is going to contract, the blood is trying to go back to the atrium, but what happened? The valves are going to close. In
Okay.
and out, in and out. Now, this is from atrium to ventricle. But now, what happened from the ventricles going to the pulmonary artery or to the aorta? So the blood is going to go in this direction. So the valves are going to be not like this, like mitral and tricuspid valve are going to be like this. So the valves are going to open when the blood is ejected. When the blood is trying to come back, are going to close. See? Up, going up, trying to go down, is going to close. Okay, so that is about the, the main anatomy. We need to talk about a conductive system, electrical circuit. Let's finish with some terms here. Systole, and diastole. Systole are actually contraction. It's a contraction of the myocardium. So the systole is mostly the contraction that start with the atriums and then continue with the ventricles. And diastole is the resting phase where the muscle is going to relax. The muscle is going to relax. Okay, so the ventricles, sorry, the ventricles are the ones who are going to relax first, and then the atrium. So in general, what we need to remember: systole, contraction; diastole, relaxation. Okay, so here's a very important topic that we need to remember. Uh, all right, so we have here, first of all, I'm
Sir,
going to put the camera again.
yeah, I can't see your the slides.
You cannot see the slide?
No, sir, I can see you. I can't see the slides.
Can you
There we
see the
go.
slide now?
Uh-huh.
Can you see the slide now? Yes?
Yeah. Yes.
Okay, perfect. All right, so here we have, we are going to talk, the previous one is clear, the previous slide? Okay. All right, so let's talk about the cardiac output. Cardiac output. What is the cardiac output? Cardiac, just listen to read the name. We have cardiac heart output. Is the exit of something. What is coming out? The blood, right? So how much is going to be related to the blood, volume of blood coming out, ejected by the heart. So cardiac output is actually the volume that you are going to eject every minute in your heart. Okay. How much blood do you think we have in the body, Eric? About
About 5 liters.
excellent, 4 to 5 liters, right? And guess what? The cardiac output is, we said that is the volume ejected in 1 minute. And the volume ejected in 1 minute for the heart is about 4 to 5 liters. So for example,
Okay.
if you have a red blood cell going into the tip of your ear, in 1 minute, the same red blood cell is going to pass in that same area. Why?
Oh
Because
wow.
everything is moving in 1 minute. All right, so cardiac output is actually the volume. So remember the volume ejected per minute. So we are going to modify a little bit that, and I'm going to tell you that you see here cardiac output is equal the volume that is ejected multiplied by the time. In this case, we are going to talk about the heart rate. That is the heart rate. If you want to take a note of that, that is really, really important. So cardiac
Okay.
output is here the same thing. Stroke volume, that is the volume that I just simplify the word, and the heart
Okay.
rate, the heart rate. Okay. All right. One thing I want to go with you is this. That is going to be very, very, very important about the blood pressure. I'm going to write down here the blood pressure. The All right. So the blood pressure is going to be directly proportional to the cardiac output multiplied by the peripheral resistance. I'm going to write it down for you, peripheral resistance. And that is, well, we are in the imaging, so we are not going to talk about too much about pharmacology or something. But just remember here, For example, when you have high blood pressure. So do you know somebody who has hypertension? Probably yes. And
Yeah.
what is the first thing that the patient is going to do in order to prevent increase of blood pressure is to decrease the amount of salt, correct? So,
Right.
so if you decrease the amount of salt, you know the sodium always love water, right? So whatever sodium is going, water is going to be after the sodium. So if you take more, more salt and you suffer from hypertension, what happens? So the salt is going to be reabsorbed to your body, and that is going to bring more water into the circulatory system. So this this is going to increase the volume, is going to increase the volume of the blood. So that means that it's going to increase the cardiac output. If you increase the cardiac output, the blood pressure go up. All right, so I want to tell you this. For example, cardiac output, volume and heart rate. How you can increase your cardiac output? So if the volume increase, the cardiac output increase. If the heart rate is going to increase, cardiac output is going to increase. So if you have more water in your, or more volume of blood in your circulatory system, cardiac output is going to go always up. The blood pressure is going up too. Peripheral resistance. Just to talk about very brief about peripheral resistance. Tell me, if you want to blow air from a straw, very thin straw, it's going to be difficult. But if you have a straw that is actually more diameter, huge straw, the flow is going to be easier, correct?
Right.
So now,
Correct.
so that means that when the vessels are what we call the vasoconstricted, so VSD, I'm going to write it down for you here. Vaso, vaso, vasoconstriction. Vasoconstriction is more difficult. It's more difficult the flow. So that is what is referred about peripheral resistance. Peripheral resistance, if you see the name, is that how easy or how difficult is the blood flow running through the vessels. Peripheral is because they go to the arms, to the rest of the body, and resistance is a force. So how easy, how difficult is going to be the blood flowing through the vessel. If you increase the resistance, means is going up the peripheral resistance, that means that the blood pressure go up according to this formula. So if you have, for example, a very thin vessel, because it's vasoconstricted, like a very thin straw, that is going to be more difficult for the blood flow, and that is going to increase the blood pressure. So what we have to do, we are going to decrease the peripheral resistance. How? Making it easier the flow. How? To make it more dilation of the vessel. So the more dilation of the vessels, the easier the flow. So the peripheral resistance go down. If that happens, the blood pressure go down. So it's a game between cardiac output and peripheral resistance. So what we need to just remember is the blood pressure is directly proportional to cardiac output and peripheral resistance. And the cardiac output itself is going to be actually volume multiplied by the heart rate. Another thing, what else we can do if the patient have hypertension? We are going to give diuretics. That's what we call the water pills. If you have water pills, you are going to urinate more, so you're going to decrease the water in the blood. So this volume go down, cardiac output go down, so blood pressure go down. All right, so that is in simple words what we just trying to talk about the cardiac output. Basic concept that we need to remember, cardiac output is the volume, blood volume that is ejected, pumped by the heart in 1 minute, period. All right, so let's keep going. Okay, so here we have, this is a specimen of the heart with the arch of the aorta. And the arch of the aorta is actually with what we are going to see in the next slide. But let's finish with the heart conduction system. Okay, so there's few interesting things, or well, more than few, about the electrical conduction of the heart. So first of all, let's orient it here in the graphic. Here we have these yellows. Can you see these yellows? All right.
Uh-huh.
These yellows are actually the conduction system. So mostly are composed by nervous system. Nervous system. We have here some dilation here, and this yellow structure where it's located in the right atrium. Then we have here another bigger structure like a node that is going to be what we call the atrioventricular node. Why is called atrioventricular node? Because they are going to be between the atrium and the ventricle. Simple. Here we have the sinoatrial or sinusal or the pacemaker. It's called the pacemaker. The pacemaker that is going to be located in the right, in the right atrium. All right, so here we have the pacemaker or sinoatrial node or sinusal node, and then we have here the atrioventricular node. See, we're talking about nodes, node and node.
Okay.
These nodes are going to go to these bundles. Can you see these bundles going all the way to the heart? These bundles are going to be called the His bundles. So it's written there. Somewhere is written there. Yes, here. The bundle of His. So where is the bundle of His? All this line. Can you see this line? All the way distributed here. All this is actually the bundle of His.
Okay.
His bundle. Okay, and at the end, we have some small branches that continues from the bundle of His that is called the Purkinje fibers. The Purkinje fibers. Purkinje fibers. So, summarizing here a little bit, we have the sinoatrial node, we have the atrioventricular node, they go to the His bundle of His, and here at the end we have the Purkinje fibers. Okay, so let's start. We have the sinoatrial node that is connecting to the atrioventricular node. The atrioventricular node are going to be connected with the bundle of His. And the bundle of His are going to end into the Purkinje fibers. So everything is interconnected, number one. Number two, we have here the sinoatrial node or pacemaker, and that is going to produce what we call the depolarization. Are you familiar with the word depolarization?
Um,
No, that's fine. Tell me. All right.
no.
So I will tell you. I will write it down. Depolarization is equal contraction, and that is means the systole. Systole. Then we have the other word that you're going to use, especially when you're going to review AKG later. The repolarization. Repolarization. The repolarization means relaxation, equal to say diastole. Diastole.
Okay.
Perfect. Okay, so let's go over the big screen again. All right, so here we have this pacemaker are going to depolarize, means are going to contract, are going to send electrical stimulus with between 60 to 100. 60 to 100 impulses. So if you can tell what is the normal heart rate in normal person, is between 60 to 100. So this
Mm-hmm.
pacemaker is the one who is giving electrical impulses that make the heart contract. And these impulses are going to be between 60 to 100 beats per minute. Then they are going to keep going, and these stimulus are going to reach the atrioventricular node. The atrioventricular node is going to depolarize 40 to 59 beats per minute. 40 to 59. 40 to 59. So kind of what happened here? Both are working together. We are going to see that in a few moments. Then we have here the bundle of His that is conducting the electrical impulses coming from the atrioventricular. Remember, the impulses coming from the pacemaker, then go to the atrioventricular, then go to the bundle of His, and then go to the Purkinje fibers. The Purkinje fibers are going to depolarize about 20 to 40 beats per minute. 20 to 40. So summarizing, 60 to 100, about 40 to 59, and this is 20 to 40. Who? The Purkinje fibers. All right, so everybody's working together? No. When the pacemaker is working normally, so they are going to send 60 to 100, but the atrioventricular node is going to keep silence. It's going to be a little bit delayed, that is an EKG sense, but that definitely what is going to happen, that atrioventricular node, when pacemaker working okay, this keep silence. Same, so they are not going to depolarize 40 to 59. So the one who is in command, that's why we call the pacemaker, is the sinoatrial node. Now, they are going to continue to the bundle of His, they are going to pass through the Purkinje fibers, and they are going to be the rate 60 to 100, because who is in command? The, the pacemaker. Now, what happened? Why do we have these different numbers? Okay, so you see these movies or some whatever ER, whatever, and some movies of medicine. They have the monitor of the heart, and sometimes the monitor of the heart beat very slow, right? Very slow and very slow, and
Mm-hmm.
and that is what the reason is this. If somebody have a heart attack, what means heart attack? Means infarction. So the cells of the muscles are going to be dead. Why? Because do not receive oxygen. So if that area that is being damaged or infarcted is going to be the right atrium, what happened with the pacemaker? The pacemaker is going to totally not work at all, because that area is destroyed by the heart attack. So if that is not working, the one who now is going to take over is the atrioventricular node. So it's better to have some beats than none, right? So that is why the atrioventricular node is a mechanism of protection uh, uh, about the conduction system. Now, if the heart attack is going to affect the atrioventricular and the pacemaker, the one who is going to take over is actually the Purkinje fibers. So, but if you have these beats about 20 beats per minute, that means that there's a massive destruction of the heart. So that patient is critical. So most likely close to death. Okay. So that is about the electrical circuit, and we are going to see this is not an EKG lecture, but we are going to talk a little bit about to give you the big idea about what is EKG. Okay, so let's go here. I want to see myself here to see how. Okay, okay. Just a moment. Okay. All right. So let's suppose that we have here. This is my team. So this is water, and we are going to throw it over a surface. For example, this like this. So I'm going to put it like that. So who is going to get wet first? Obviously this area, and then this area, and then this area, and then this area. So this water is going to represent, I'm not going to throw water, but this water that is running in that direction is going to get wet here, then here, then here, then here. That is what happened with the electrical impulse. The electricity that is coming from the pacemaker or the sinusoidal node are going to send electrical impulses that are going to arrive first to this area, second to this area, then here, and then here, and then here. And that is the basic thing for EKG. So let's go here to the. So in this case, if you have the pacemaker, I'm going to put it B here. You have the pacemaker. The pacemaker is going to send electrical impulses. These electrical impulses are going to go like this. first like this, like a waves towards the apex of the heart. So here, the electrical impulse in the atriums, what is going to do? It's going to produce the contraction of the atriums. So that is what is first happening. So you and I, we have the pacemaker working properly, and the first electrical impulses are going to arrive to the atriums. That's why the atriums are going to contract first. Then the electrical impulse go to the ventricles. In the ventricles, when they arrive, the electrical impulse to the ventricles, that is the moment where the ventricles are going to contract. Now, so who is first to contract? The atriums. Then it's going to be the ventricles. Okay? All right. So keep that in mind. Now, here we have the atrium contracting because the electric impulses pass first for this area first, second, third, and so on. So they are going to contract the atrium, and then they are going to go to the ventricles to contract the ventricles, but at the time that the ventricles are contracting, the atriums are relaxing, okay? And then the ventricles are going to, after contraction, are going to relax again. So what is doing this is it. Contraction of the atriums, relaxation of the atriums, contraction of the ventricles, and the relaxation of the ventricles. Now, what I want to tell you is this, and please, this is kind of a little bit difficult to grasp, but the contraction of the atriums is going to happen first. Second, simultaneously and coincidentally are going to happen at the same time the contraction of the ventricle and the relaxation of the atriums. And then at the end is going to be the relaxation, of the ventricles. Again, contraction, relaxation of the atriums, but at the same time happen the contraction of the ventricles, and then happen the relaxation of the ventricles. That's what we are going to see now. All right, so look at this curve. This is a basic curve or waves of the EKG, electrocardiogram. So you see here, first of all, you have, remember the letters, P, Q, R, S, T. P, Q, R, S, T. P, Q, R, S, T. Now, this is the beginning of the EKG. This is the first wave, the wave we call the P wave, everything that is in green here. Then we have the QRS, and because there's kind of many waves here, is we call the QRS complex. QRS complex. QRS complex is Q start here, exactly go a little bit down, and then go up, and then go down again, and then go up again. So all this is the QRS complex. Then we have here the T wave. All right, so P wave, QRS complex, and T wave. So talking about P wave, what is the P wave? P wave is going to be the electrical manifestation or changes of the in the first part of the heart contraction. What is the one? What structures are contracting first? Are the atriums, correct? And the atriums are going to be represented with a P wave, P wave, P wave. So what is P wave? Atrial contraction. Atrial contraction, because it's the first area where it's going to start contracting in contact with the electricity coming from the pacemaker. Then they go to the ventricles. And what is this? That is the ventricular contraction. Ventricular contraction. Ventricular contraction. So all these Q, R, S, up to here. S is from here to here. That is the ventricular contraction. Then we have the T wave, and the T wave is going to be what we call the ventricular relaxation. The ventricular relaxation. So, but you will tell me again, where is the atrial relaxation? So, P is atrial contraction, but the atrial relaxation is going to happen at the same time that the ventricular contraction. So that's why in EKG we cannot see the atrial atrial relaxation. So what we see only is the P, that is the contraction of the atrium, QRS, the contraction of the P, sorry, is the contraction of the atriums, QRS is the contraction of the ventricle, and the T wave is the relaxation of the ventricles. One more thing I want to tell you. Remember we was talking about the thickening of the walls of the ventricles, very thin wall here, a more thicker wall here on the left ventricle. So, but if you compare with the myocardium of the atriums are actually a big difference. The atrium myocardium are going to, atrium myocardium is going to be much more thinner than the ventricles. So that's why, look at this. This is atrium, P wave. But the QRS is a huge wave. Why? Because there is more muscle. And why does it mean more muscle? Because it's passing or it's needed more electricity. More electricity. So the more they go up, the more differential potential R means more voltage. So, and that is needed for a myocardium that at the level of the ventricles. And let's compare the P wave with the T wave. T wave is the relaxation of the ventricles, and the P wave is the contraction of the atrium. The T wave is bigger than the P wave. Why? Because they have the muscle is more thicker than the atriums. Okay. All right. Any question, Eddie? I'm trying to be clear. If you have something to clarify, to repeat, just let me know,
Oh
please.
no. That's very good. I can understand that. It's very clear.
Thank you so much. So let's keep going. All right. So here we have the bradycardia, so variations of the heart rate. We have the bradycardia and tachycardia. Bradycardia is less than 60 beats per minute, and tachycardia is more than 100 beats per minute. All right, so we have the heart sounds, that is the loop. You can write down there the loop. Loop means the closure of the mitral and tricuspid valve. And DUP, DUP, is the closure of the semilunar valves. Again, so LUP is the closure of the mitral valve and tricuspid valve, and DUP is the closure of the aortic valve and the pulmonary artery valve. LUP-DUP, LUP-DUP, LUP-DUP. Murmur, when you're going to hear in your imagine they're going to talk about murmur. And what is murmur? Murmur is something that you can hear, sometimes you can pulp. Just go, what is a murmur itself? Murmur is actually when the blood flow is turbulent. So turbulent blood flow produce murmur, turbulent. If you, for example, you have a river and you put a stone in the middle, there are going to be some turbulence around, right? That is the way sometimes the blood is running, especially when they are going to divide vessels or when you have presence of cholesterol. Okay, so classification of some heart diseases. We have anatomical classification. Endocarditis is the inflammation of the endocardium. Myocarditis, inflammation of the myocardium, and pericarditis, inflammation of the pericardial membrane. Okay, so there is different. I'm going to let's see. All right. So here we have some examples of the. All right. So I think we are going to go over through the veins here or arteries. And let me see if I have a picture I want to see with you here. Just a moment. Okay. All right. So here we have the arch of the aorta. The components of the aorta are going to be the ascending aorta, go up. Then we have the arch of the aorta. Then we have the descending aorta. The descending aorta is going to be thoracic descending aorta. then the aorta perforate or pass the diaphragm, and the rest is going to be the descending abdominal aorta. All right, so what I want you to remember is a few things. Here we have, first of all, I want you to remember that there is 4 main vessels coming from the, going to give blood supply to the upper and the neck, upper extremity and neck. So what is this? This is the carotid artery. What is this? Subclavian artery. Again, what is this? This is carotid artery, and this is actually the subclavian artery. Okay, so this is 4 branches: subclavian, carotids, and carotids. We call the common carotid artery because after that is going to bifurcate in 2 more. So common carotid artery, subclavian artery, common carotid artery, subclavian artery. What you need to remember here is that they arise from directly from the arch of the aorta, whom the left subclavian artery and the left common carotid artery. On the right side is different story, a little bit. We have the same vessels, but they are coming from a common branch that is called the innominate artery, like can you see here in the screen, or we call the brachiocephalic trunk or brachiocephalic artery. So what is the first branch? If they ask you, what is the first branch of the arch of the aorta? You will say properly the brachiocephalic trunk. What is the second artery coming out from the arch of the aorta? You said the left common carotid artery. What is the third branch coming from the arch of the aorta? You say the left subclavian vein, artery, sorry. Okay? Is that clear or help a little
Oh
bit?
yeah. Yeah,
Okay,
that
so
clears it up.
let's go over I want to go over the brachiocephalic veins. Let me see if I have a picture here where I put it. Okay, so it's not here, so let's go over because I'm running down out of time. Okay, all right, so this is the best I have so far at this moment. All right, so look at this. Here we have we are talking about veins. The head is going to receive the blood supply, head and neck is going to send the blood return to the superior vena cava through the through the internal jugular vein, the internal jugular vein. This is the internal jugular vein. Where is coming from? What is bringing blood to the internal jugular vein? From the head and inside the head. So all these brain blood supply with return are going to come back to the internal jugular vein. Now, internal jugular vein are going to join together with the subclavian vein. This is the subclavian vein. You see subclavian vein. So
Mm-hmm.
this subclavian vein together with subclavian vein on the right side and the internal jugular vein together form the brachiocephalic veins. Brachiocephalic vein. So try to imagine in 3D the other side. So we have a jugular vein with a subclavian vein and forming the brachiocephalic trunk on the other side. Now, that is mostly it. So what is happening later? The 2 brachiocephalic veins, the right and the left, coming together in order to form the superior vena cava. That is all. So, so who is forming the superior vena cava? The 2 brachiocephalic veins. Who form the brachiocephalic veins? The, the subclavian artery, or vein, sorry, and the internal jugular vein. So we have internal jugular vein plus subclavian brachiocephalic vein. From the other side, the 2 brachiocephalic veins coming together, they are going to form the superior vena cava. That is how the vessels are going to drain blood into the right atrium. All right, so now I want just to finish this with a few things about it. Okay, let me put a camera here.
Yeah, I
Uh,
can hear you.
oh, all right, so let me see. Okay, there you are. All right, so are you familiar with the names of the upper extremity? We have the basilic name. You recall that basilic name?
Uh-huh.
Basilic vein and the cephalic vein, correct?
Okay.
We have
Uh-huh.
the basilic vein is, let me put my hand, basilic vein is going to start here, all the way from the forearm to the arm. This is
Okay.
the basilic, and this is the cephalic here on the top. Everything here,
Okay.
the
I
cephalic.
see it.
Okay. So now remember, basilic is the base, correct? Base, base here. This is the basilic.
Okay.
This is going to be the cephalic. Remember always that lower and upper extremities, we have two venous systems, the superficials and the deep vein system. The superficials, you can see, is about half centimeter below the skin. So that's
Uh-huh.
how you can see the veins over the skin. So these superficial veins always are going to drain into the deep vein system. Who is the deep vein system here in the upper extremity? Remember, we have the radial bone here, radial bone, sorry,
Mm-hmm.
radial bone. That is going to be the radial vein. We have the ulnar here. This is the ulnar vein. Those are deep. You cannot see it. They are going to be deep inside, close to the bone and muscle, between muscles and bones, so that you cannot see. Then they're coming together, the radial vein and the ulnar vein coming together to form the brachial vein. The brachial vein is going to go, is deep, going to change name when they go to the axilla. It's going to be called the axillary
Uh-huh.
vein. And then go, the axillary vein is going to change name and is going to form the subclavian vein. And why is called subclavian vein? Because it's running under the clavicle, clavian vein. So this is the deep vein system. So my point is that the basilic and the cephalic are going to drain always into the deep vein system. In this case, into the axillary vein. Axillary vein. This is very important because you are doing radiology, imaging, you're going to see many patients going to have catheters, and they are going to insert the catheters to the basilic go all the way up. They're going to drain into the deep vein system, in this case the axillary, go to the subclavian vein. The subclavian vein go to the brachiocephalic trunk, and they go to the right atrium. So that is actually the main thing. Probably you need to have some drawing that is going to help you to to uh, to know the names. So at this moment, what I want is just to get familiar with the basilic and the cephalic. Now let's finish with the lower extremity. In the lower extremity, we have, for example, let's start with the bones. The femur. The femur is on the thigh, right? And the femur is actually is going to run the femoral vein, femoral vein. Then we have under the knee, or here we have, this is the femoral vein. Then they are going to go posterior to the leg, and that is going to be the knee, right? And that is called the popliteal vein, popliteal vein, popliteal vein, popliteal vein. We are talking about the deep vein system, vessels that you cannot see are immersed in the muscles and bones. Then we have the anterior tibial vein. We have the fibular vein or peroneal vein and the posterior tibial vein. So we have anterior and posterior tibial veins coming from the tibia. So the name is coming from the tibial bone. And we have the peroneal or fibular that are another branches in the middle that are coming together to go into the popliteal vein, then go into the femoral vein, then go to the change name is going to be the external iliac vein. When is going to change name? At the level of the groin. So you have here the femoral vein is in the femur, in the thigh, and that when they go pass up towards the beyond the the groin is going to be called the external iliac vein. The external, if you have external, you have internal. So this little one you see here is the internal iliac vein. So internal iliac vein plus external iliac vein is going to form a common vein that is called the common iliac vein. Common iliac vein. This common iliac vein joins the other common iliac vein and is going to form the IVC. So the blood is going to go in this direction. Again, we have the posterior tibial vein with anterior tibial vein. We have the peroneal vein. They are going to come together to form the popliteal vein. The popliteal vein. Then they go and it's called the femoral vein. The femoral vein is passing the groin, and now the femoral vein is changed name. It's called the external iliac vein, and the external iliac vein is going to join the internal, because we have external, we have internal. External iliac vein forms with the internal iliac vein, the common iliac vein, to form the IVC. Okay, so that is the deep. And we remember we were saying that the superficial veins drains into the deep. So here's the proof. Look at this. Here we have, this is the superficial vein. In the superficial vein, so this is what you have when somebody have varicose veins. This dilation of the veins, that is what produces the varicose vein. And this is the vein that we need to remember. That is going to be called the greater saphenous vein. The greater saphenous vein. I'm going to try to make it bigger. Here we have the greater saphenous vein. Here, the greater saphenous vein. Don't get confused. Look at this. Where is the saphenous vein? Here. Start here on the foot. This is the main branch here. Keep coming, all this blue, behind the knee. That's why it disappear there. Here, can you see the curve? It's coming behind the knee. Then they go up again anteriorly, and they go and drain into the femoral vein. So all these gray saphenous vein are going to drain into the deep vein system that is the femoral vein. All these branches that you see here are tributaries. So they are going to bring blood to the saphenous. So all this actually is called saphenous vein. The main pathway of the saphenous vein is this one. Okay, so here we have the great saphenous vein. If we have a great saphenous vein, we have a small saphenous vein. And the small saphenous vein is going to start from the calf. This is the leg. And here the calf. So the lesser is going to start in the calf here, and they are going to drain into the popliteal vein. Now, my point here is how to remember where is the great saphenous vein. Number one, I want you to never forget this, please. Just to remember, okay? So that is just to remember. Tell me, but first tell me, the tibial bone. Tibial bone is medial or is lateral on the leg?
Lateral.
The tibial bone, no. Why I'm saying that, because it's very easy to not get confused, but easy to figure out. All right, so listen to this. Never forget this. It's going to help you a lot. Okay, so the tibia and the fibula, which looks is more thicker?
It's the fibula that looks more thicker, right?
Who is more thicker, the tibia or the fibula? The more thicker is the tibia.
Okay.
Okay, all right. So more thicker is the tibia. All right. So we have the more thicker, don't forget this, the more thicker is the tibia. Why? Is just to remember, in what side is the biggest toe? Medial or lateral?
Medial.
Medial. So the big toe, just to remember, is going to be on the side of the more widest bone, that is the tibia.
Oh, okay.
Got it?
Okay.
So
Got it.
the tibia is medial. One. Second, tell me, who is bigger, the greater saphenous or the lesser saphenous? The greater saphenous, correct?
Great.
In what side is going to be? Well, it's going to be the widest bone and the big toe. So it's medial.
Okay.
So the greater saphenous vein are medially, and the tibia are medial. Okay, medial.
Okay.
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 All right. So I was trying to make it as short as I could, but definitely time is short for us.
Yeah.
I hope that this helping you, and we will see you next week. Any questions, please, yes, you can go into the forum, and I will be more than happy to help you at any question that you have.
Okay. Are you gonna have these PowerPoints?
Yeah, the PowerPoint is already there.
Okay.
It's
Okay.
already there, so you can see the same images from this PowerPoint that you saw.
Okay.
Okay. All right, Mr. Eddie, keep going. Take care of yourself. Okay. I will see you
Yes,
next
sir.
time. Thank you for coming.
Thank you very much.
Thank
All
you
right.
too.
All right. Bye.
Bye.